All right, it's time we can start right away. And today we'll be looking into multiple energy-based devices treating pigmentary disorders and melasma. And first and foremost, we'd like to invite Professor Paolo Bonan from Florence, and he's going to share with us faster, pain-free, and excellent results with powerful and selective fractional beams of red coherent lights at 675 nanometers wavelengths for skin rejuvenation and melasma. Please, Professor.
Well, the third thing is wrong, and it's been a long time since we saw each other. Few minutes. Okay. So all the friends and colleagues in the room here, I'm very happy to be here. Thank you for inviting me to talk. Well, this is the topic I was assigned, and is a really revolutionary, as you know, is this particular wavelength, and this wavelength is characterized by, it does work, some problems? Try to, okay, just by myself. Well, what about this new wavelength, about 675? The protagonist of, as with the other laser and energy-based devices, is the collagen. But in this particular platform, the collagen has been one of the protagonists because this kind of laser has been developed from the diagnostics field. In this particular study has been studied the collagen as one of the parameters to distinguish, to estimate the breast cancer between the benign lesions. So it's been one of the important targets in the investigation. From the diagnosis, by using the particular, the functional modality that they depicted, that the collagen has been developed, the laser. So from diagnosis to the therapy. This is a fascinating aspect of this new laser that for us has been revolutionary. It's a really forefront technology. This is the wavelength that drops exactly where we have two main chromophore, collagen and melanin, you see in the top of the line, and very, very low absorption by the vascular, hemoglobin and the vessel wall, of course. So it's not a vascular laser, but we will have some surprise for that. We have three main pathways to study this kind of laser and wavelength. First of all, we have to say that it's fractional, but it's not ablative fractional. This is an advantage. We'll see why the features of this are important in particular ways. We have performed a lot of study over the past 5 years to evaluate from the prototype to now. From the simple Van Giesen study for the collagen fibers and the type 3, and before in the previous session, my friend Ting Son explained that the role of collagen type 3 is not typical of hypertrophic scar because it's a stationary collagen, right? It's a very evolutionary collagen, means that we are changing the tissue, and then has been studied in with elastic fibers with the Van Giesen, and with the picroceros red, that is a particular stain that we used for evaluating this passage of the collagen, and even some odal fibroblasts in culture has been studied with this kind of wavelength. So a lot of studies, not only this, to support our good clinical results. We published a lot. One of the most important was in Asian skin type, to evaluate the safety profile and not only the efficacy, because you know better than me that your skin is particularly sensitive, and we have the great result PIH. And this is our studies. Another important practical part is that we can use in standard mode and even in the Moveo modality. So we can move the NPs so we maintain the safety profile. Some clinical cases to go to the practical part. Well, we studied for the photorejuvenation. Look at what happens if you consider that immediately after this kind of treatment, we don't have any side effects. Only a modest erythema and a sort of paradoxical darkening or some pigmentation. And look at what's happening under the chin. And the jawline, there is too much light. Maybe we can see, can we switch off one of the light there? Maybe just close to the screen so you can appreciate better. So the jawline and even cheek, and you see here the jawline and the neck, and some, I run on that so you can respect for time. Even just in a 70, 80 years old female, you see the jawline area under the chin. 1-2 sessions consider, no more, 3 sessions. 83-year-old female, jawline again, and cheek, and please note the laser level and meridian lines. The other side, and the cheek, and this part, the neck. Look at this, even just under the chin. And the jawline, once again, reducing the laxity. The 48-year-old female, look at the wrinkles in the cheek, coarse wrinkles, sometimes with even with the thick skin, sometimes really surprising and terrific in this view. For example, you can see 2-3 sessions, and look at the date over there, just very recently, 2025, one of the recent cases that we treated. And look at the vessel here that after the treatment disappear. 3 sessions, mobile modality. Look at the parameters. We don't use the parameter here in this, and when I have some Asian patient, I don't use that parameters, or better saying, I use that parameters, but in standard mode, I enlarge the spacing so that we maintain the safety, and with the Moveo, I speed up the Moveo modality so that you can maintain the safety profile in the Asian skin type. Look at what happened here. There is a reduction even of the vascular part, not only the impressive tightening of the skin after this kind of wavelength, and after the chin, smooth area, really, really terrific, totally unexpected. We have used a scan field that characterized the possibility to, with the algorithm, to evaluate the displacement of the skin and the tightening capability. But what about melasma? That is a topic of today's agenda in this session. Even in this case, we publish with this wavelength because we are really, really characterized by great results. And there are 3 pathways that can be considered where we want to know the mechanism of action of this laser in particular. The first, interaction with the fibroblasts and the building blocks, the collagen. So there is an important study. It is not our study, but I think it's mandatory to study this. If you want to take a screenshot of that, because it's very important to know that fibroblasts and building blocks can play an important role in the melanogenesis. So this is one of the way that we can use, because the collagen, remember, with this wavelength is one of the main chromophore. This is one step. Then we have another step, the melanin. But you have seen that the second main chromophore is melanin. So it's very intuitive that can happen, can be effective in melasma. But the third, what about the third? We know that the microvasculature can play an important role. It's a key role in the melasma in many parts of the world. But why there is an important reduction? S is not considered a vascular laser. Our hypothesis that we have studied in our university and laboratory is that the collagen remains the main protagonist, but it's not the collagen alone, but the collagen of the vessel wall can be important in the just interaction of the pathogenesis of melasma, and even the rejuvenation process that we have, even with the injectables. If you improve this part, you have good results even in melasma. So it's a very complex word, the melasma, not only a challenging condition. But look at a lot of several cases that we have, dozens of cases that we treated. The first one that we treated before, and look at the vascular component and after. Not only there is a reduction in pigmentation, but even the vascular component. Once again, and the clinical results. This is a case, reduction in melanin and even the vascular component. Melanin and vascular. This is melanin. You see the blanching area with the melasma and vascular component reduction. This is my collaborator, Dr. Troiano, Michela Troiano. Michela has, after the third guide, this melasma before and after. Once again, look at the vascular component. And this is before and after. This is another case. Before and after, melanin and vascular. Before, melanin and vascular. Even the dark skin type is Massimo Vitale, is a friend of mine that collaborated in a multi-center study about this wavelength. Before, and look at the great capability to improve. Doesn't work. Doesn't move. Okay? This after. Look at the melanin. Even in the dark skin type. So we must consider this very, very dangerous, risky. But we can just move with the flexibility. And thanks to the versatility of this laser, we can move the parameters and adapt to the skin. In this case, phototype 6, but can be in the 3 types of Asian skin types, can be adapted to that. So it's so important to see this because for us, we have to change our modality. Sorry, because the work. Okay? Well, let me conclude with these 2 cases. The first is particularly important for me because the patient was out from the breast cancer after 5 years, and you can see the face immediately after the rescue period, and he started to be treated with Red Touch. That is a name with this time, let me say, because there is no competitor in the market, but the wavelength is 675 nanometer. And look at after the 4 session, look at the lateral side, under the chin, there was a great tightening, nice glow. There is a tan skin, of course, but you can see nasolabial fold, the cheek, nice glow, new zygomatic area, because we get maybe a booster effect due to the new shape of the collagen of this capability. You see the tightening under the chin and the neck. So totally different. Was not only a aesthetic procedure, but even a medical affair. Even in this case, why it's so important? Sometimes they overlap. Aesthetics and medical affair are always together, and we have to take care of that. I'm really proud. And this one of the, look at the dates. So it's the last was May 25, just 15 days ago. Look at the under the chin. This has been done 2 sessions, 1 month apart, without any side effects immediately after the treatment. That's why we are really surprised for this kind. At the very beginning, we didn't believe. We are obliged to take a photo documentation for the honest behavior, first of all for you, for the colleagues, and then with the patients. And then we got these kind of results. You see the extreme laxity under the chin, the cheek, and lateral side of the cheek. These are our parameters for this patient that we conclude this particular patient, and the great capability to tight the skin, even very difficult, hard to treat skin. So you can see that Red Touch, the 675 nanometer, can meet not only a patient expectation, but even our expectation, because in our clinic is a core for any procedure we apply, because it can be combined without any side effects, can be combined with other procedures, even with injectables. We have made tests, a lot of laboratory tests with the hyaluronic. There is no interaction. There is no breakage of the collagen bundles and so on. So we can combine even with that. You can imagine the importance in our procedure to have this wavelength in our clinic, in our office, for complete our procedure. Thank you so much for your attention.
Thank you very much for a lovely talk with all the great results. So we'll leave the question and answer to the end. Next, I would like to invite Professor Gochilok, where he will share the lasers and light devices in melasma and update. Please.
Thank you. Good afternoon, ladies and gentlemen. First, I want to thank the organizer for inviting me to give this lecture on lasers and light devices in the treatment of melasma. And all of you know melasma is actually a very challenging condition to treat. Is there any change? Well, I'll discuss this with you because there are some new development. And in the past, we've been using lasers. And always patients will say that, can I have laser treatment? But we know that it's never a first-line treatment. So basically, melasma is diagnosed clinically, and there's no laboratory test to confirm it. And they usually do not respond to any laser treatment, to be frank with you, because most of them will either get PIH or they get better and then they will relapse again, and you never really cure them. And therefore, in my opinion, combination treatment and persistent treatment and continuous maintenance treatment is essential if you want to treat the patient with melasma. And most patients that does treatment with lasers will end up with things like that. So almost everybody will get post-inflammatory hyperpigmentation, especially the Asian population. So in the Caucasian, you may not see post-inflammatory hyperpigmentation, but in Asian country, almost everybody will get post-inflammatory hyperpigmentation. You have to warn the patient about that, and the patient may not be happy once they develop PIH. And so we all treat melasma in a very multifunctional way, that every target area that we can achieve, we'll try to do that. So combination treatment is probably the best treatment. And you can see that laser is actually only one of the small methods that we use to treat melasma. So it all started many, many years ago in the early 15, 20s, where the pigment laser was introduced, and Nd:YAG lasers as an ablative laser was also used because it's supposed to be non-ablative and supposed to cost less. But in this study, almost everybody who was treated developed post-inflammatory hyperpigmentation, and because of that, nobody used any ablative treatment anymore for treatment of melasma. This is before the era of fractional lasers. And then with the advent of the pigment lasers, the Q-switch Nd:YAG, Q-switch Ruby, Alexandrite lasers, and various combinations, we have the same problem. In fact, a lot of them became worse. And because of that, it's slowly out of favor. And this is one publications by New One that shows that Nd:YAG laser actually treating melasma had a very big group of patients with post-inflammatory hyperpigmentation, especially in the Asian population. So because of that, I don't think any one of us actually use the pigment lasers to treat melasma anymore for Asian skin. Then came the IPL. IPL is a very mild device, and it is a polychromatic light. It is not a laser, but it helps in the pigmentation because it covers the spectrum of the melanin absorption spectrum, and patients get better. And there are 2 reports earlier on to say that they have very good results. But all of you who have used IPL will know that patients don't get complete clearance, and the patients are never really very, very happy, but they are quite satisfied with the outcome. And the reason is that a lot of times when we treat patients with IPL, patients has got concomitant lentigines and other superficial melasma pigmentation that can be removed with those treatments. A patient gets some improvement. And they come back for you to have more treatment in the form of a maintenance treatment. And in fact, that's what I always tell my patient now. IPL is very safe. It rarely causes post-inflammatory hyperpigmentation, but it makes your skin a bit clearer, cleaner, and you can come for maintenance treatment after the initial treatment for about every 6 months to keep the skin clear, and the patient is quite happy with that. So there's a way of using IPL, and I think it's a very useful device. It's a very cheap device, and it can still help in some of the superficial pigmentation that helps to reduce the total pigmentation. So it is useful, but it is not clear. So that's how you can use IPL. Then came the advent of fractional lasers, and there was this report from New York that says that we had very good results, 75% to 100% clearance in 60% of the patient, and even in Asian patients. And I think all of you have tried this, and we have tried that. And a large proportion of the patient actually develop post-inflammatory hyperpigmentation. In Singapore, we did a study, and there were at least 25% of the patients who develop post-inflammatory hyperpigmentation. But the good thing about these fractional lasers hyperpigmentation is that they are more short-lived and they are less severe. So if you have lighter skin type, you can still try that. But generally, for darker skin type, the risk of post-inflammatory hyperpigmentation is very high. And in fact, in Thailand, they report as high as 90% of patients who have fractional lasers or PIH. So we never use fractional lasers for patients with melasma since then. And this is just one of the reports. Out of the many reports, you can see that in Thailand, they reported up to 92% having PIH from fractional lasers. So fractional lasers actually, although it's very safe in Caucasian skin, is not safe in our Asian skin at all. And there are quite a number of reports that follows that after that, and this is a laser toning technique, which we are still using it. Basically, laser toning technique was introduced by Newart and his group, and then it became very popular by using very low energy, big spot size, and then you just wave the laser on the surface of the melasma skin, and you do it every 2 weeks or a month, and then you find that the patients get improvement. But again, it is not complete clearance, and it doesn't give you a permanent reduction. The patients will relapse once you stop the treatment, but nevertheless, it helps in the patient. And subsequent to that, there are many publications, and these are just a few of the publications. So everybody try it, and it does work to a certain extent. 60 to 70% of the patient get a reduction in the pigmentation. But almost all of them have got a recurrence once you stop the treatment. So the conclusion is that yes, then 64 Q-switch Nd:YAG laser toning is safe and it's quite an effective modality. And a lot of people actually started using that, and you can see that there are many studies that come about. But towards the end, there was a study done by the Thai Dr. Watanakrai that shows that yes, it does improve. So they get about 75% of the patients who actually get improvement. But about 14%, and this is our case in Singapore too, that develop this mortal hypopigmentation that looks like gutted hypomelanosis. And they usually appear after repeated treatment or many treatments when you start seeing white spots on the surface of the skin. And these white spots, they are not treatable at all. I mean, you can try fractional lasers, topical cream, tacrolimus, and all that. And they are, in fact, looks worse than that of patients who has gutted hypomelanosis or hypermelasma. And again, so we warn all the patients that, be careful when you use this laser toning. Once you see white spots, you better stop your treatment because otherwise it can be very hideous. And on top of this, in this study, they showed the patient can develop rebound hyperpigmentation. In other words, instead of getting better, initially they clear, but about 3 months later, they found that they have a relapse. And the relapse is even worse than the beginning of the lesions. And this is actually a picture to show some of the relapse that occur on the one-sided studies. So it's got some serious complication. So it has been reviewed to see whether it works, but again, most of the reviewed studies show that it does work to a certain extent. But you must watch out for those complications, the gutted hypomelanosis as well as the rebound phenomenon. So you can use it, but you have to use it with care and watch out for complications and warn the patient about the complication. And this is the gutted hypomelanosis that I tell you. And all of you who have done laser toning will have experienced this anyway, because initially nobody knew about it or was not conscious about it. But subsequently, when this was publicized and everybody wrote their experience, they found that it is actually quite serious and it's not treatable in a sense that they don't clear even with all sorts of treatment. And the reason why this appears is from an electron microscopy study done in Korea is that when you do laser toning, the laser actually does cause stunting of the melanocytes. And you can see that the dendrites disappear and they start to produce less and less pigment. And that's how you ended up with gutted hypomelanosis. So, but they don't seem to recover after a period of time. And we reported this in the literature, and the Korean reported this mortal hypopigmentation, which is a very serious complications with laser toning. So usually we don't use laser because of all these complications that I've told you about. And lasers are generally used as a second line or third line treatment in the management of melasma. And only when patients are very disturbed and insist on having treatment, and the treatment is recalcitrant and refractory, that you want to then offer the patient the treatment. And subsequent to that, of course, picosecond laser came about, and everybody was shouting, very happy that, oh, this new picosecond laser is not going to give us any problem at all because it has a short pulse duration, mainly a photoacoustic effect. So that's the picosecond lasers. And we actually tried that, and we did some studies at the National Skin Center, and we found that there's no difference in terms of its complications and its efficacies in terms of clearing melasma. So this patient, for example, has melasma and had laser toning done, and the melasma remains almost the same. Although normally if you use the Nd:YAG lasers, Q-switch NDX lasers, you do get some improvement. But in this picosecond, the outcome is exactly the same. They either get better slightly, or they don't improve at all. So there's no added advantages as far as Q-switch or picosecond lasers are concerned. We know that Q-switch laser is inferior to picosecond lasers when you're treating dermal melanocyte pigmentation, like Horace nevus, nevus of Ota and all that. But when it comes to superficial pigmentation, then we found that actually the picosecond has no advantage. So if you have a picosecond laser, good. But if you don't have it, stick to your Q-switch NDX lasers. You also know a lot just now. I think Dr. Bona has also mentioned about the vascular nature of patients with melasma, and this is discovered by the Korean and who discovered the presence of increased endothelial growth factors in patients with melasma. But if you try to treat the patient with vascular lasers, which they claim can improve the melasma, you'll find that not everybody will respond. Some of them will not respond at all, zero. And then you have to warn the patient and know how to identify the patients. So if you do a skin biopsy, you'll find this increase in vascular cytokines, factors 8 stains and all that in patients with melasma, indicating that there is probably a role of vascular element in melasma. And if you look at this patient, for example, you will see that there's some telangiectasia, some vascular effect here. And these are the type of patient that you examine who has got melasma that is going to respond to vascular lasers, like the pulse dye lasers or even IPL. So if you select them carefully, you may get better outcome when you are treating the vascular component. And this is another study done by the Thai, where they use copper bromide lasers, which is a vascular lasers, to treat patients with melasma, and they did not find any improvement. Whereas another group in Korea find that there are some improvement using the copper bromide laser. So the results is very arbitrary, and we are not very sure what's the role. But if you choose your vascular lasers carefully for specific patients, then you probably get better result. And I want to round up to the end to talk about what Dr. Bona has mentioned, and that's the role of fibroblasts, because there's a lot of new development in melasma, and we know there is a multifactorial skin disorders, and people have honed in on various cytokines and connective tissue association, and the latest, of course, is the role of fibroblasts. They think that the fibroblasts secrete certain cytokines, and this cytokine has got an effect on the pigmentation. And in fact, we are now doing a study on a new drug to see whether it works, because people are now looking into cytokines and trying to produce monoclonal antibodies. And some people think that some of the lasers, like what Dr. Bona has mentioned, has got the effect on some of the secretion of cytokine by the fibroblasts. So we may see new one. And some of the studies that has been reported include things like using microneedling for the treatment of melasma, and they get fairly good results. I won't go into detail, but this is just the beginning of everything. And here's another review of the use of combination treatment that gives you much better results than by monotherapy alone. And there's another new treatment using this micro focus ultrasound again, thinking that it probably has got effect on the fibroblasts and secretions of fibroblasts and fibroblast cytokines that can help to reduce the effect of the melanophages as well. And this is a study done by Dr. Joyce Lim, who shows some improvement. And you can see that this improvement usually is very subtle, because I saw Dr. Bonan's picture also. The improvement is there, but I think it's very subtle, and we need more studies actually to know that. So there are some improvement according to the report, and this is something that I think we will see more of it coming up. And the report says that 80% was quite satisfied with the outcome. And there are some more other studies, as you can see, using radiofrequency microneedling for refractory facial pigmentary disorder, not only for melasma, but all other pigmentary disorder, which we will have to watch out for in the future. And there are some reports again to show you before and after picture. But again, you can see the improvement is very subtle, not the type that we would like to see. And there are some discussion about using devices to target again dermis for melasma maintenance treatment as well, again, which was mentioned by Bonans. And you may have to keep on treating patients to maintain their pigmentary recurrence. So there's no single treatment actually that will help to eradicate the melasma completely. And there are many ways of doing it, and we must keep an open mind and do combination treatment for this. And this is my last slide, and then just to remind how I feel about using devices. It's never the first line treatment. Topical treatment is still the first line. And recently we have the oral tranexamic acid, which we have a lot of experience in now, that can give you very good outcome and result, which you should consider in treating your patients. A lot of laser treatments are pretty expensive because to buy the devices, and many of these conditions actually do not really respond 100%. And there's a risk of PIH, and then patients need maintenance treatment. So sun avoidance, topical treatment, and combinations of them are still probably the best treatment in the management of melasma. Thank you very much.
Thank you very much for your nice summarize and updates us about laser and light treatment for the melasma. So we move to the next topic with Dr. David Johannes Forrest. So he will tell us about the facial dyschromia. How can we differentiate diagnosis and treatment in different conditions of facial dyschromia? So please welcome Dr. David.
Thank you very much for the introduction. So good afternoon, everyone. So in this session, I'll be talking about facial dyschromia, specifically paradoxical dyschromia or exogenous ochronosis, and iatrogenic dyschromia from the use of skin lightening agents. I do not have any conflict of interest in this lecture. So dyschromia is defined as alteration of skin color, either hyperpigmentation or hypopigmentation. So it's usually mixed, or unusual hue, such as the gray color. Most common in skin of color or in darker skin phototypes. It may be found on the skin and the nails. The occurrence is unpredictable, and until now we don't know if there's a genetic predisposition, but we have proven that it's a consequence of photoaging. And there's a huge component of what is called post-inflammatory pigmentary alteration. Facial dyschromias is more recently a common complaint in skin of color. And in fact, it is becoming a global health problem, especially in emerging countries or developing countries, such as in Southeast Asia. The classification of facial dyschromias in one publication includes melasma, lichen planus pigmentosus, facial acanthosis nigricans, maturational dyschromias, post-inflammatory pigmentation, vitiligo after treatment, and salt and pepper pigmentation. But until now, there is no standard for classification. It is currently being defined from publications by features, clinical features, histopathology, and dermoscopy. Facial dyschromias has now become a cosmetically disfiguring condition, and it's becoming more and more common. It has some psychological and social stigma. Some post in social media that it's becoming a global health problem, but we understand that it's a complex public health issue involving the marginalized population or patients who belong to the low-income bracket. And for the dermatologist and the other physicians, the treatment is very challenging. So I'll be discussing paradoxical dyschromia, or what is called exogenous ochronosis, and iatrogenic dyschromia from the use of skin lightening agents. So we all know that exogenous ochronosis is common in darker skin phototypes. The color is usually black. It's due to hydroquinone bleaching creams and exposure to phenolic compounds. Sun exposure is usually implicated, and sites of predilection is similar to photoallergic dermatitis. And the main pathology is accumulation of homogenesic acid because your hydroquinone interferes with your enzyme. So these are clinical photos of exogenous ochronosis included in the first case series that we have published. But it's very important to recognize that the confetti-like depigmentation has an atrophic feature. And when you do a biopsy, it is actually a scar, which is different from the guttate hypomelanosis that Prof. Go was talking about earlier. And these are just a photo. These are two photos which differentiates exogenous ochronosis from another patient, which we have published, having endogenous ochronosis or alkaptonuria. And these are some of the patients included in the first case series, including one male. And on dermoscopy is very reliable. in making a diagnosis of exogenous ochronosis, where you see the brown to black pigments obliterating hair follicles and pores. And this is a dermoscopy of the confetti-like depigmentation, which is quite different from what you see in idiopathic guttate hypomelanosis. This is the pathology, and we are often amazed by the banana-shaped, ochre-colored pigments, but most of the time we do not understand that the homogenesic acid in exogenous ochronosis irreversibly binds to collagen and eventually destroys it by disruption of collagen cross-linking. And there is collagen stiffening, hardening, and collagen degradation, and this process is irreversible. So this is a far advanced state of ochronosis where you see dermal atrophy, collagen degeneration, pigment deposition, and signs of sun damage. And the patient is just like 50 years old. And on higher magnification, we see severe solar elastosis. So there is a sun damage component, ochronotic pigments, severe collagen degeneration, and dilated blood vessels. So if we review the related literature, there's no consensus on effective treatment. The lasers are unpredictable with inconsistent results. Some researchers have tried the Q-switch alexandrite pigment lasers. In one case report treated with a picosecond laser showed satisfactory results. And then it's time, I think, that we revisit skincare, discontinue irritating skin lightening, and anti-aging products if we don't know what to do with ochronosis. And the combination treatments for exogenous ochronosis, our goal is to fragment the pigments, fragment the ochronotic pigments, preferably with pigment lasers, photoprotection, and attempt to nourish the dermis with cosmeceutical injectables. Collagen remodeling is very important because we have damaged a lot of collagen already, and address the abnormal vascularity. So this was the first patient in the case series treated with the Q-switch NDAG monthly with the following parameters. And there was a significant improvement after 4 sessions. And histopathology shows active macrophage activity in exogenous ochronosis after 2 monthly low-fluence Q-switch treatments. So the macrophages are eating up the fragmented ochronotic pigments. So these are follow-up biopsies where we demonstrate very active macrophage activity. And follow-up histology using the CD68 stains shows very small ochronotic pigments being eaten up by macrophages. And in this patient, I combined Erbin-YAG and Q-switch NDYAG, and the result is thickened epidermis, fragmentation of ochronotic fibers, recruitment of macrophages, and good dermal remodeling. And this was the patient after several sessions of lasers, so 11 sessions, Q-switch NDYAG, Erbin-YAG resurfacing, 4 sessions of the 577 nanometer yellow laser for the vascularity. But interestingly, after about many sessions of the following combination, I used the 675 nanometer collagen laser under the brand name Red Touch for 6 sessions, and you can demonstrate the improvement. And this was the patient on both sides of the face with significant improvement. And her friends used to tease her that she was using charcoal for her makeup. But now she can already present herself in a very nice way with very light makeup because of the significant improvement. This is another patient who was treated with a Q-switch NDYAG, Erbin-YAG, plus 4 sessions of the 577 nanometer yellow laser. She improved for some time, but then after a while, it recurred a little bit. So these are the recommended treatments of exogenous ochronosis, but sometimes there is a rebound pigmentation. So I'll go to the next disease entity. It's called facial iatrogenic dyschromia. This is a complication arising from the prolonged use of skin lightening creams containing hydroquinone, topical steroids, The clinical presentation is similar to pigment laser-induced dyschromia, where you see mottled pigmentation on the foreheads and the cheeks. And it can result from cosmetic use of skin bleaching products or iatrogenic hypopigmentation from pharmacological agents which induce a chemical leukoderma or imatinib. And the pathophysiology involves epidermal melanocytosis, which was described by Bernie Ackerman, where you see increased melanocytes in the basal cell layer, but a lot of UV actinic damage in the dermis. So this is a relatively younger patient presenting with facial dyschromia after using skin lightening products for a long time, and at the same time, I think she has genetic predisposition because she also had ABCD, or acquired brachial cutaneous dyschromatosis, on the arms. This is the histology where you see melanocytic proliferation in the basal cell layer in both the face and the arms. So these are just some dermoscopic features of iatrogenic dyschromia, where you see the abnormal pseudo-reticular network pattern, hypopigmentation, depigmentation, and increase in the number of blood vessels. And we might be thinking whether these patients actually had a rosacea component. For the differential diagnosis, and which may provide clue to the pathogenesis, the dyschromia is very similar to amyloidosis cutis dyschromica, where there's deposition of your amyloid in the papillary dermis, and xeroderma pigmentosum, where you have a genetic abnormality. So on histology, we see prominent hyperpigmentation of the epidermis, and then you'll take note that in most of the biopsies, there is severe solar elastosis. Even if the patients are young, we see injured melanocytes stained by the melanase stain and apoptotic or sunburned cells. And there's very prominent solar elastosis and degenerated collagen. We see sunburned cells. That means the patient failed to do proper photoprotection, and there's massive solar elastosis and subpigment-laden macrophages. So our goal for the treatment of facial iatrogenic dyschromias is to strengthen collagen or remodel elastic fibers through laser remodeling, photoprotection, skin lightening agents, which are alternative to hydroquinone, such as kojic acid, azelaic acids, and the new kid on the block, the biomimetic WNT inhibitors. Correct hypopigmentation, I've tried before, but I don't see significant results with tacrolimus, bimitoprost, and laser-assisted drug delivery, or the use of excimer laser to repigment the hypopigmented macules and address the abnormal vascularity. And we wonder whether injectables have a role. So these are just two patients who I tried in the 675 nanometer laser for 6 sessions. And this is a very bad case of iatrogenic dyschromia. And they used, and both patients, they are sisters, they used skin lightening agents containing mercury, hydroquinone, and steroids for a very long time. And this is the patient after 6 sessions. You know that it's very hard to treat this condition. This is the sister who was also treated with 6 sessions of the 675 nanometer laser. And I think the reason for that it is that it is able to regenerate new collagen. So what are the take-home messages? Exogenous achronosis and iatrogenic dyschromia are both cosmetically disfiguring, and they result from prolonged use of skin lightening agents containing hydroquinone, mercury, and some other ingredients such as steroids. And up to now, there is lack of standard of care to address these conditions, and we have to admit that. And most of the dermatologists have to experiment on treatment modalities. However, we are offered some new lasers, which I think are effective in addressing these conditions. The treatment should target pathophysiological mechanisms involved, especially the damage in the dermis. So we don't just address the hyperpigmentation or the increased melanocyte or the abnormal melanocytes in the epidermis, but we have to encourage dermal remodeling. So with that, thank you very much for your attention.
Thank you very much, Dr. Derek, for your presentation. I think your result looks so nice with difficult facial dyschromia. So move to the next speaker. So the next speaker is my colleague from Thailand, Dr. Suparut Leung Arun. His talk is about the exosome therapy, a novel approach for hyper and hypopigmentations. Please welcome Dr. Suparut.
Hello everyone, I'm Suparut from Bangkok, Thailand. It's really my honor to share with you about the, I think it's quite news for in our practice. It's about the exosome for hyper and hypopigmentary disorder, a novel approach. Exosome, as you know, is an extracellular vesicle, secret for the cell-to-cell communication. The major mechanism of action is anti-inflammatory and regeneration effect. What make exosome unique and efficacious is their content about the microRNA. They have anti-inflammatory and they have many effects. Hair regrowth, anti-scarring, and promote collagen synthesis. And what concern in the pigmentary disorder, they have the function of anti-melanogenesis. And you have to check which product. There are a lot of exosomes in the market. So I think you have to check that your exosome have the important microRNA or not. So for the exosome and pigmentary disorder, this is an example that UVB-induced keratinocyte to produce the microRNA that increase the melanin production. So for the most important ingredient, as I mentioned to you, is about the microRNA. MicroRNA can regulate the MTIF pathway, and most of the pathway regulated by the microRNA, they will decrease the gene expression and have the inhibit the melanogenesis inhibition. But some of the microRNA have the function of upregulate the melanogenesis also. So from the review of the literature, we have some information about the exosome therapy. Most of them are in the hyperpigmentation, and we have found some reported cases about in the hypopigmentation treatment also. Most of them we have to use in combination with the procedure like microneedling, fractional ablative or non-ablative laser, fractional RF microneedle, or any transdermal drug delivery, because currently exosomes are not approved to be injected yet. So for the hyperpigmentation, you can combine with any procedure to increase the laser or procedure transcutaneous drug delivery. This is the first study. This is a quite interesting study. They use the stem cell-derived exosome in combination with many procedures in the treatment of melasma, and they found that they decrease the symptom of melasma. This study, they use non-ablative fractional laser, microneedle, non-ablative fractional laser in combination with exosome, and plasma device. They all show the improvement of the melasma. And what this study is also, they study about the penetration depth of the exosome into the skin. So this suggests that you use the microneedle or non-ablative fractional laser or plasma device, you can make the exosome go deep into the dermis to what we would like to target to treat. And this study also used the microneedling in combination with exosome. They show the improvement of the facial aging. And the recent study, they used the microneedling with the plant-derived stem cell exosome in the facial dermatosis, pigmentation, solar lentigo, including the melasma. We found that they significantly decreased the epidermal pigmentation, but not only the epidermal pigmentation, but they improved the skin texture and skin quality also. So in my practice, at first when I got the exosome, I had tried to combine with the standard treatment, and we found a good result. And then I would like to see, is that exosome alone in combination with the microneedle and fractional RF microneedle, is that work? So we can see the improvement. This is from the dermoscopy also. And fractional RF microneedle in combination with exosome, we can find the improvement in the pigmentation also. And in the case, and I do the split face, then I perform the split face, fractional pico, low frequency, and applied exosome, we found the improvement. But the site treated with the fractional pico alone, we found the rebound hyperpigmentation. So this is what we should be concerned. And then the case with the gutted hypomelanosis and melasma, I tried to use the power wave fractional RF microneedle and exosome. We found the improvement in the pigmentation and skin quality also. And as you can use the exosome had anti-melanogenesis effect, so you can an anti-inflammatory also. So you can use in any hyperpigmentation disorder. I think this example for the post-inflammatory hyperpigmentation, for the dark eye with dark eye circle, I use the power wave fractional RF microneedle in combination with the exosome. This is the example of the cases. Or even like the post-inflammatory hyperpigmentation, I use the simple method like electroporation to increase the transdermal drug delivery in combination with exosome, and we found improvement. Not only for the hyperpigmentary disorder, what we have found some evidence, but no publication yet about the hypopigmentation. You can combine with our the procedure to improve for the most concerning condition like vitiligo. Vitiligo, as I mentioned to you, that most important ingredient in the exosome is microRNA. Some of microRNA have the function to inhibit the melanin synthesis, but some exosomes have the function to promote the melanin synthesis also. So this is my pilot case with only one session of the fractional CO2 laser in combination with rose stem cell derived exosome. You can see some of the repigmentation. This is ongoing for the collect for the data. And that's you can see some repigmentation after the fractional CO2 laser in combination with rose stem cell derived exosome. And not only for myself, but the dermatologists from around the world. This is from Dr. Felipe from Spain. He treated with the fractional erbium laser in combination with exosome. You can see the repigmentation in the vitiligo cases. This is for the axillary hyperpigmentation. You also found the improvement of the vitiligo treatment. This is from the Dr. Pamela from Indonesia. She treated genital vitiligo with the technique of fractional picosecond laser and exosome. You can see the repigmentation. And another case from around the world, you can see. So, and what you have the problem with the idiopathic gutted hypomelanosis from the Q-Swiss and DIAC. So I treated fractional CO2 laser in combination with exosome for 2 sessions. You can get the repigmentation. Or even the scar with or burn or wound or scar with hyperpigmentation or hypopigmentation. I used in combination with fractional pico, fractional CO2 exosome, result in normalization of the pigmentation. So, and another that are ongoing to our process of research is that about the idiopathic gutted hypomelanosis. This condition is from the aging, sun damage, and also resulted in the decreasing in the melanin synthesis. I use the low fluent of fractional CO2 laser and combined with the rose stem cell derived exosome and electroporation and occlusion. You can see from the first treatment, you can see the improvement. This is from the only single treatment. You can see the repigmentation, and this is a pigmentation improvement, and some lesion almost gone after 1 session. And also, not only for the skin, but for the hair, we also observed not only hair regrowth, but we observed some hair repigmentation. Not only for myself, from around the world also. This is from Dr. Felipe from Spain also. He not grow the hair, but we get some repigmentation. This is, and what we have reported is the case with the poliosis circumscripta, more than 10 years, not resulted from the vitiligo, not resolved by spontaneously. He come to me because he want to have the hair regrow. So I use the technique with fractional picosecond laser in combination with the exosome. You can see not only hair regrow, but he got the improvement of the poliosis area. And then after 10 months, he got the, again, the white hair area come back again. And then I use this technique, fractional picosecond laser, in combination with exosome, and then he got the repigmentation. This is example of the moscopy. You can see more black hair in the white hair area. So this is, so what is the explanation? I think currently we do not have the clinical trial to prove this efficacy yet. But what makes the exosome unique is about the unique ingredient is about the microRNA. MicroRNA could have the inhibit melanogenesis. And some microRNA have the function to upregulate melanogenesis also. So this is the proposed protocol for the treatment if you want to use exosome. For the hyperpigmentation, as our professor already mentioned, you can use Q-switch, pico, fractional RF, microneedle, or peeling. Or for the hypopigmentation, maybe recommend to use the fractional ablative laser, fractional CO2, fractional erbium, or phototherapy. And you use the topical exosome and not only electroporation, but any method to increase the transdermal drug delivery, ultrasound, electroionophoresis, or everything to increase the absorption, and then occlude for maybe 6 to 12 hours, and use there are also some of the exosome majority to promote the pigmentary disorder. So the take-home message, I think the most important is exosome microRNA could have the function to modulate melanogenesis. They have the microRNA that upregulate the melanogenesis, and some of the microRNA have the function to downregulate the melanogenesis. Currently, we are not allowed to inject the exosome, so I think combination therapies could enhance the efficacy, like fractional CO2, fractional microneedle, and so I think exosome are the promising adjunctive therapy to the pigmentary disorder currently. However, we still need more study to confirm this efficacy. Thank you so much.
All right, this is such a great talk. We talk about hyper and then hypopigmentation. So the next speaker will be Dr. Pillai Rahul, he will share about an update on the management of melasma. Please.
Thank you very much. Glad to be here. It's an honor to be here. First of all, I'm happy that we have a hall with enough people, even though it's the last session. So I'm going to speak about what's new in the management of melasma and what are the options and what's safe. Honestly, the first thing a patient comes to me, I tell them is, okay, I'm not looking at getting you cured completely because I'm not sure if I'll be able to do that. I tell them to take melasma as a disease, the same way as you would take any systemic disease like hypertension or hypercholesterolemia or asthma, etc., because it's never going to go away. But my intention is to get it under control. And if you're cooperative and on a long-term basis, we can get it under control. So that puts the expectation level right there where it should be, because that's the most important thing. Because you never know. Because I've realized with personal experience, there are cases where melasma improves on its own. I wouldn't want to take credit for that. And sometimes, no matter what you do, it doesn't respond. So it's quite a tricky question. I'll be, okay, it's over here, is it? Okay, there's none for the talk. I'll be taking the names of multiple brands. It's not because I have, any specific interest in them. I'm on my own. It's just that certain things are done by certain companies and it's patented and there's no substitute that works. I always do believe that whichever is the innovator company, the product of that company eventually works best for that particular indication. Okay. Now, a few words about melasma. As we know, it's easy to diagnose. It's quite common, more common in women than in men. It's multifactorial. And it's seen in darker skin type. So we have classified melasma into 3 types basically. One is the epidermal, the dermal, and the mixed. Broadly speaking, if it's the epidermal, it's quite easy to treat. No matter what you do, it responds fast, so the patients are quite happy. If it's dermal, even if you treat, it's going to respond, but it's going to come back most of the time. And mixed, it's a bit tricky. Now, risk factors, you have the genetic family history, which is quite a interesting thing actually. So that is something which you have to consider. Pregnancy, as we know, is one of the other factors which can be a stimulation point. Hormone therapy, certain drugs, and hormone variations, excessive sun exposure, cosmetics. One second, it's irritating, this noise. Excessive sun exposure, cosmetic applications, darker skin type. So all these are probably the factors that we have to consider. The most important thing about melasma is we still don't know exactly what is causing it. We have a lot of theories behind it saying it could be due to that, it could be due to this, but then you could ask a question back, okay, if it's predominantly because of hormones, why is it coming in males? Or there are patients who's going to come to you say that I don't have much of sun exposure, so why is it happening? So there's not much of explanation to understand what really is happening, but more or less, these are the provocating factors. Now, this is the pathophysiology. You can see that there's multiple, points where it is attacking or creating this pigmentation. The UV light is actually stimulating keratinocyte. There is various VEGF activators, the plasmin, the arachidonic acid, so prostaglandin. So the whole idea of understanding the pathogenesis, as I always say, is understanding pathogenesis as a clinician is very difficult, because if you're a private practitioner, many a times we tend to forget after we study actually. But any medication that is indicated at treating a disease is indicated at stopping a particular pathophysiology at some point of time. So whatever medication is going to come out in the market, or whatever where we're trying to intervene, is going to intervene at some pathway of this pathogenesis. So by understanding the pathogenesis, we can understand how to handle this problem. So as you can see over here, it affects various parts: the melanocytes, keratinocytes, basement membrane, fibroblasts, masses, endothelial cells. So whatever medications are available will be targeting any of these pathways or particular situation. Now, treatment options. The basic thing for any treatment of melasma or any hyperpigmentary condition would be sun protection, which is of foremost importance. So sunscreen is a must. That is the basic thing. You got to apply it 3 times a day. Okay, any protection against infrared rays or visible light is also of importance these days. Anything that inhibits melanogenesis, mast cell stabilization. I won't be going over in detail. It's quite evident, because I'm sure that all of us know that these are the various options that we have in front of us. I'll go each and every particular topic so that we don't waste time. Now, this is the first treatment option that was invented in 1975, the Klingman formula. Now it has been modified Klingman formula. We have the hydroquinone, tretinoin, and actually fluocinolone. Now, the problem with this is it's banned in a lot of countries. It's not available in Europe. It's there in US, if I'm right. Asia, it's there in Middle East, and it's there in India. I'm sure it's there. I probably assume it's there in Thailand too. It gives fabulous results. It's a value for money treatment, because if you are going to ask the patient to apply it regularly, they are going to get treatment, but results. But the point is, how long are you going to apply it? Rook's textbook of dermatology says don't apply beyond 4 to 6 weeks. But the truth is, if you're going to stop it after 4 to 6 weeks, it's going to come back, rebound back. So that is a challenge that all physicians face. So that's a bit of a tricky question, which we have to deal clinically. Now, hydroquinone, the hydroquinone system per se, or the hydroquinone, is, according to me, still the most powerful, what is tyrosinase inhibitor. So if you are used hydroquinone and you're using any other product, the truth in reality, as a clinician, we know it doesn't give the same kind of results. But again, it's got its own, side effects or possible, rebound pigmentation, lichen planopigmentosis, ochronosis. So these are the complications, especially on darker skin type. Now, you have the New-Derm system, which I find the most effective, actually, when it comes to, if a patient comes to you saying that, okay, I'm not looking at applying steroids or tretinoin, etc. Okay, I'm looking at something which I can manage at home. I don't want to come regularly to your clinic. Probably this would be the right treatment of choice. But again, studies have not clearly shown that after 4 months or 5 months, can you still continue the hydroquinone? So that's a question again, but it does give results. So most of the time, if a patient has got not very severe melasma, you can try them on the New-Derm system and afterwards change them over to some skin lightening creams, actually. So this is my patients, actually. You can see that after 3 to 4 months, there's quite a good significant improvement, actually. So that's one good choice. Azelaic acid. Azelaic acid is a weak tyrosinase inhibitor, but the only advantage is it can be used in pregnancy and lactation. Azelaic ideally is a pigment lightening. It can be used for acne, rosacea, or PIH because of acne, etc. I won't say that it's ideal for melasma, but then considering if on the scenario and the situation, it is one medication which you can try. Kojic. Kojic is also quite a good pigment lightening. I use it very often for priming of the skin or normal skin pigmentation. I will not say it gives excellent results in melasma, but it's one of the treatment options. The most important problem with kojic acid is to get the preparation stabilized. So choosing the right preparation from the right company can always be a bit of a challenge. Ascorbic acid. So this vitamin C, today morning I had a talk about lasers, and they asked me how priming patients do you use vitamin C? I was mentioning about it. Now the thing is, this is something which you can use quite safely. So if most of the time what happens, I don't know over here, for me what happens is most of the time the patient comes to you after the melasma or pigmentation has got quite worse. Probably they are self-medicated, they applied various OTC products which may or may not contain steroids, they don't know about it. So they come to you with damaged skin. You can't immediately put them on any treatment or any kind of procedures. You need to calm the skin down. So what I do is I actually tell them apply hyaluronic acid or some skin calming agents for, let's say, about 4 weeks. Then probably we can start off with a weak pigment lightening. I would call it weak actually, because ascorbic doesn't do much of a pigment lightening, but it helps actually in improving the texture, evening out things. So that way ascorbic would be of use. Tranexamic acid. Now a lot of people ask, is tranexamic acid application topically, does it help, or does the injectables work, or does it work systemically? The literature is over here, but from personal experience, I would say what works best would be oral tranexamic acid. So now the question is it safe? Most of the time, if you're given at the right dose, not beyond 250 milligram twice daily, it doesn't cause much of any fibrolytic or thrombophobic events, so it's pretty safe. It does give results, because when you compare patients on tranexamic acid tablets orally twice daily, and when you stop it, you do see that a bit of melasma comes back. So I assume that if there's a vascular component attached to it, probably this could be one option that you can combine with your topical agents, not as a monotherapy. Now this is about dermamelan. Actually, this particular product actually is from Miso Aesthetic. Again, no conflict of interest. I've got nothing to do with this company. So their product, retinolic acid, which has got ferulic acid, diosmine, and melaphenone, which is a patented technology, works similar to hydroquinone. What I've seen of personal usage of this product for the last 1 year is actually hydroquinone, if I'm going to put them on a Newderm system for about 3 to 4 months, and I do a dermamelan or a cosmelan peel, I'll be coming to a slide of cosmelan, I do get the same kind of results. At the end of 3-4 months, the results is more or less same, because the benchmark of pigmentation is still now hydroquinone. So we are comparing dermamelan or cosmelan to hydroquinone. But the problem is you can't continue hydroquinone beyond a point because of the risk of various complications. So this way, probably dermamelan and cosmelan is a treatment which you can do, and the patient can maintain in a long term, because after 4 months, when you get your results, you can lower it down and use it twice daily at night and maintain it as long as required, because it doesn't technically, theoretically have any side effects. So you see the results are pretty good at the end of 4-month therapy. It's a peel procedure. You have part 1 cosmelan or dermamelan, stage 1, stage 2. First you do a procedure in your clinic, then you send your patient back home. There is a specific protocol when you're managing, because I was in Spain, we had, the way they're written in the box is different for Caucasian skin, maybe for an Asian or a darker skin type, Fitzpatrick 4, 5, 6. We may have to go in a little more less aggressive, because there's always a tendency for pigmentation or irritation. But as you can see, the results are pretty good, and I think it is quite effective. So this is of cosmelan, which is probably a little more milder than dermamelan, but honestly, with practical experience, I can say that patient seems to be more happy with cosmelan than with dermamelan. Although technically they say dermamelan is what a doctor should be using or a dermatologist should be using. Cosmelan is something which could be promoted not just by a doctor, it can be any aesthetician. But in my personal experience, probably because we are treating darker skin type or we are treating sensitive skin type, cosmelan is giving the same kind of results, and at the end of 4 months, I did not find much of a difference between cosmelan and dermamelan. And even this has got melaphenone, although other active ingredients are slightly different between cosmelan and dermamelan. So it works in various ways. Basically, it works like a peel. So it has an epidermal turnover, it reduces the number of melanocytes or the melanin production, the keratinocyte, and all kind of pigmentary intervention. So what happens eventually is the same like what you do a peel actually. But besides doing the peel, it also does control the melanogenesis. So that's how probably you're going to get a long-term results. So you can see from the results, that's pretty good actually. Even for mild pigmentation, acne or PIH. So most of the time I have patients not just for melasma alone, even it could be any kind. I've even tried it for LPP, although it's not a theoretical indication for LPP. It does work actually, because LPP is a condition where I say actually there's no technically nothing really gives you 100% results. I always use the term throw the kitchen sink, because you try everything. You try pigmentation creams, you try oral, antioxidants, you try peels, and eventually something seems to work actually. So other peels that I use is yellow peel, acylic peel, TCA, phenol. Yellow peel is something which I say is always value for money, because the cost for a yellow peel and a Cosmelan is a huge difference. Actually, a yellow peel probably comes 1/4 the cost of a Cosmelan or Dermamelon. It does work. The main ingredient over here is salicylic acid actually, so there is a bit of peeling effect, skin lightening effect. And only thing, you may have to do multiple number of sittings. So to get the same kind of results, for one Cosmelan, you may have to do 4 yellow peel. That's what I've seen actually. So if a patient wants immediate, you are sure the patient is not going to come to you, then probably a Cosmelan is a better choice. But you're looking for a value for money, probably yellow peel is an option. TCA peel. TCA does work. Around 5-6 years back, it was TCA, which was the mainstay of treatment when it came to melasma, because it just peels off and the patient is quite happy. Again, there could be a rebound actually, so that's challenging. So this is about TCA. I'm not going into detail over there. Or Q-switch NDR fractional CO2. This is the combination that I've been using in my clinic actually. Lasers are not the treatment of choice for melasma, although when it comes to Pico-Way, I'll show in my next slide actually, is quite effective. So what I do is I do a combination of fractals. Initially I do a fractional CO2. After some time I do a Q-switch. So otherwise, alone with Q-switch, what I've seen is there is a bit of smudging of pigmentation and the patients are not quite happy. So they come back to you saying, I think the pigmentation is reduced, but it's spread actually. So when I combine with the fractional CO2, I feel the number of sittings are less. We're done, right? Just one more minute. And results are pretty good. Now, this is from a doctor from here, if I'm right, Dr. Winche Hongcheru. Yeah, I think it's from Thailand actually, because I just bought the Pico-Way actually. And just for information, although we say that a Q-switch laser or Pico laser is indicated for melasma, the only US FDA laser is Pico-Way actually. So this is the results I've seen from this doctor, which I met him in IMCAS last year. He's got really good results and he's been consistently giving great results. I've never tried it in practical experience, but I've seen publications and presentations by him giving excellent results. And last, PDL, pulse dye laser. It's not something which a private practitioner can actually afford, because unless you have so many patients coming in regularly, because there's a consumable cost. Once you open the can, you need to use it. But pulse dye laser does work if you think that vascular component could be one of the major causes of recurring melasma. So in short, I would say that melasma is still a challenge. There's no permanent solution to it. We are looking at controlling the problem, but we have various options by which we can actually control this problem quite satisfactorily. Thank you.
Right. Thank you, Rahul, for the overall lecture. So without further ado, we'd like to invite the last speaker, very famous dermatologist from Japan, Dr. Konotaro, to talk about the treatment strategies for pigmented disease using picosecond lasers and education of Grant from Laser Optic.
Thank you for having me. Today my topic is a treatment strategy for pigmented lesion using picosecond lasers. As you know, the summer relaxation time of the melanoma is less than 50 nanoseconds. The long pulse laser effect is a photothermal effect, and the short pulse laser is photomechanical effect. Even the use of Q-switch laser only confirm thermal, but not mechanical. So after Q-switch laser irradiation, plasma formation causes shock wave. Even the size of the melanoma is 1 micrometer, but the vacuole is much larger than the size of melanoma. As the peak power of picosecond laser is significantly higher than Q-switch laser, it means if you confirm mechanical effect of picosecond laser, the fluence is much lower than Q-switch lasers. This is the comparison with summer relaxation time versus strike relaxation time. The strike relaxation time of melanoma is much shorter than summer relaxation time. As for mentioned, summer relaxation time QC laser confirm summer, but not confirm, confine a mechanical effect. So after QC laser irradiation, there's a big vacuum hole, but after picosecond laser, it's very small. This is a comparison of picosecond laser versus nanosecond laser. Picosecond lasers less PIE, it means less PIH. No PIH in picosecond laser side, but PIH was observed in nanosecond laser side. With this comparison study, pico and nano, the risk of hyperpigmentation is higher in QC lasers. And also, we did different fluences. Therefore, 0 picosecond, there's no either P and no erythema. This is immediate after. 0.6 joule, some either P and some ashegray appearance. 0.8 joule is obvious either with P, or 1.0 joule is much more obvious. After a week, no other P area for result, no erythema. Some other P good result and no erythema. Either P plus, excellent with slight erythema. But 2 plus is a little bit more erythema. The wound healing of epidermal area is regeneration. So you can choose long pulse ruby, long pulse lasers, continuous wave lasers, QC, picosecond, any laser. But in the treatment of dermopigmented lesion, we have to use QC or picosecond laser. The thermal relaxation time of the epidermis is 1.6 to 2.8 millimeter. So you can use hair removal laser to treat pigmented, superficial pigmented lesion also. The first report of nevus of odor is reported from Dr. Watanabe from Japan, and QC ruby laser is the gold standard. This is before and after. The result is excellent, but there's a risk of complication. As for mentioned, QC lasers hit not only melanosome but also melanocyte. The complication rate of QC ruby hypopigmentation is 70%, 17%, QRX 10%, and YAG 7.6%. And there's also some hyperpigmentation after QC laser treatment of nevus of odor. We did the comparison study with picosecond and nanosecond in the treatment of nevus of odor. The treatment time to achieve excellent result using picosecond laser is much smaller than nanosecond laser. This is picosecond laser side, and this is a nanosecond side. And after full treatment session, the patient, this is pico, and this is nano. Not only the improvement, but also complication rate is different. You see there's no hypopigmentation in picosecond laser side, and this side was treated with nanosecond to achieve excellent result. It takes 8 treatment, and you see hypopigmentation in nanosecond laser side only. And there's PRH in nanosecond only. We also did a comparison with 1064 in the same result, but the risk of hypopigmentation is basically lower. So the efficacy picosecond laser is much higher. A Mongolian spot. The most biggest problem of Mongolian spot is hypopigmentation and the hyperpigmentation after QC lasers. But picosecond laser, 10th for picosecond, the risk of hypopigmentation. We treat 30 patients and 108 treatment sessions. There's no hypopigmentation. Only one patient caused mild hyperpigmentation. And this is before and after. All children were treated without general anesthesia. Using large spot size with very low fluence, we don't need general anesthesia. We also evaluate the threshold fluence of picosecond laser with different wavelengths and different spot size. We use Posen scans Melasma. This is before and this is after picosecond laser. We evaluate the size of melasma. This is 532 nanometer. Green is before, and red cross is after with lower fluence, and this is the high fluence. There's no difference between sizes before and after up to 0.8 joule, but more than 0.8 joule. There's significant difference of the size. It means there is threshold fluence in the use of picosecond laser. There's two ways. One way is if you increase the fluence, the number of melasma destroyed according to increase like this. But another way is there's no significant difference, but at some fluence, significantly increase to decrease the number of fluence. This is the threshold fluence. And this is 730, and this is 755, and this is 1064. 730 and 755 and 1064 also there's a threshold fluence. And also we did a Monte Carlo simulation, and this is 532, 730, 755, and 785, and 1064 with different spot size. This is very interesting. 732, 2 millimeters, 3 millimeter, 4 millimeter, there's no significant difference. So if you want to use a 532 picosecond laser to treat epidermal pigmented lesion, you can use small or you can use a large spot size, no difference. But when you use 730, 785, and 785, and 1064, larger is better. So if you want to treat deep dermal pigmented lesion, better to use a larger spot size. This is the summary. E is epidermis, UD is upper dermis, and DD is deep dermis. And blue bar is 2 millimeter, 3 millimeter, and 4 millimeter. It's the same. So to treat epidermal pigmented lesion, 532 nanometer is the best because other wavelengths needs higher fluence. 532 nanometer picosecond laser, you can use the lowest fluence. But if you want to treat dermal pigmentation with 532, you have to use much higher fluence than 730, 755, 785. So dermal pigmented lesion using 532 is too risky to cause dyspigmentation. Deep dermis is much higher, so you should not use 532 to treat dermal pigmented lesion. But 1064 is good to treat deep dermal pigmented lesion. But if you want to treat epidermal pigmented lesion using 1064, you have to use very high fluence. So this is also not good because high fluence causes PIE. PIE has a risk to cause PIH. So in the use of 1064, better to treat deep dermal with large spot size. But 730, 755, and 785 is good to treat epidermal pigmented lesion and deep dermal pigmented lesion. But if you treat a deep dermal pigmented lesion, better to use large spot size, even the use of 730, 755, and 785. In conclusion, the selection fluorescence melasma disruption determined to each wavelength. If you use short wavelengths, the selection fluence is lower, and if you use the long wavelengths, the fluence much higher. And the spot size is also different. In the use of larger spot size, you can treat deep dermal area. But in the use of 532, you don't have to, there's no difference. So 532 is especially for superficial pigmented lesion only. The strategy of laser treatment or pigmented lesion, we have to think about wavelengths, path duration, fluence, spot size, and also endpoint. But diagnosis is the most important. Thank you for your attention.
Thank you very much. So it's always hard to find that balance. Due to time, I think we will just close this session. If you do have questions, feel free to approach the speakers and get some clarification from them. With that, thank you very much for all of you who stay until the very end. And thank you all the speakers for the very lovely talk. Thank you very much.